Thank you for your invitation. Congratulations to the organizers for this great Congress. I'm going to talk about the superior capsular reconstruction with biceps, the best option. I don't know if it is the best option, but I'm sure that is a good alternative to many kind of tears and the rotator cuff lesions. Disclosures known for this presentation. So the problem, several treatment options for large to massive rotator cuff tears exist. As you heard about it in the other speeches, we mentioned arthroscopic partial repair, biceps tenotomy, for example, the balloon, or another alternatives which are still in study and concern. So the superior capsular reconstruction was first described in 1993 by Hanada et al. To treat recurrent posterior supermassive rotator cuff tears, especially in patients with paraplegia. It's important to know that because in the first description of the superior capsular reconstruction, we have a weight-bearing joint because these patients use crutches to walk. The superior capsular reconstruction was widespread when Dr. Mihata published the first groundbreaking clinical results of arthroscopic superior capsular reconstruction in patients with irreparable posterior superior rotator cuff tears using an autologous fascial lata graft. As we know, this famous article describes the technique and the clinical outcomes. So the glenohumeral joint has an optimal function when the center of the rotation remains stable during the normal range of motion. For this to happen, a dynamic equilibrium has to be between the vectorial forces in the vertical and in the horizontal planes for the humeral head. That's why the superior capsular reconstruction described by Dr. Mihata works. When we cut this restriction, the center of the rotation of the humeral head moves superiorly. That's why the tendinopathy and the arthropathy begins. So we can reproduce this restriction with another graft, with another option, yes, the long head of the biceps tendon. So the question is if the long head of biceps tendon is equivalent or not to fascia lata for the superior capsular reconstruction. And there are some collaborative studies which demonstrate that the long head of biceps tendon is still sufficient and enough to restrict the migration of the femoral head superiorly. For example, in the first one, we need 3 times the normal force to move the humeral head superiorly, and 2 times more force when we use fascia lata. Then the long biceps tendon is stronger. So there are many advantages talking about the long biceps tendon versus fascia lata. So it's biomechanically equivalent, less demanding technique because we don't have to put any anchor in the medial zone, the glenoid tubercle. Is lower socioeconomic cost, has lower socioeconomic cost because we don't need these anchors in the medial side. So we have less morbidity because we don't have to get the graft from another zone in the body. For example, the fascia lata, we harvest it from the leg. The viability of the graft is better because we have the medial insertion intact and the vascularity too intact. We have good outcomes. Yes, we have good outcomes. There are many studies about the clinical outcomes. For example, this is systematic review where they conclude that it is equally effective with the traditional superior capsular reconstruction when we use the long head of the biceps tendon. But I think the easy part is to perform the surgery. The hard part is to knowing who to operate on and what to do. So how can it be? We have to know when it's too late or when it's too soon to superior capsular reconstruction. It doesn't matter what kind of rod we use. So the main indication for superior capsular reconstruction is an irreparable posterior superior rotator cuff tear with preserved glenohumeral cartilage, so that this surgery is a preservation surgery. It can preserve a joint that has a very damaged cartilage. In addition, you have to think in three factors. One, can you effectively close the box with a primary repair? This means that you shouldn't be able to bring the posterior superior cuff to its native footprint without either undue tension or risking neurological damage. The second one is, can you still reduce the humeral head to the original core? Can the head migrate inferiorly again or not? In order to restore the fulcrum system, the humeral head must be reducible when the patient is in the orthostatic position. And then, if is the glenohumeral cartilage preserved or not? As we said before, superior capsular reconstruction is not an interposition arthroplasty, and it will not restore the mechanical restraint or the pain produced both by the absence of cartilage and the subchondral bone-to-bone contact. So that's why we perform the superior capsular reconstruction with healthy cartilage. To whom we perform this procedure? Irreparable massive and retractor tear, no in patients with Dalton dysfunction or nerve injury or active infection. Sorry. How we perform the procedure? We think we perform the easier way to this procedure. I don't know if it's. Sorry, a minute. Oh, it's not running. I don't know if you can solve the running of the video, please. It's not running the video. Oh, now, yes. So we make a measure and release the long head of the biceps tendon. We decorticate the footprint and we move the long head of the biceps. We mostly perform medial and lateral fixation in the lateral tuberosity like this. We prefer the lasso loops to attach the long head of the biceps like this. We don't tight the knots at first. We prefer to put the lateral anchor to tie all knots. So in this way, we have a very good fixed long head of the biceps tendon, and when we cut it, it's a double row configuration of fixation in the lateral tuberosity of the biceps. Then I perform partial repair, trying to join the biceps tendon with the infraspinosus posteriorly to close the box, to complete a very close construct above the humeral head. This is a case of a patient 2 years ago. as you can see, is a big, massive tear, rotator cuff tear, and, oh my God. This is the video of this patient.
Maybe عشان maybe as
So we can find a very large, massive tear, and we have an intact insertion of the biceps tendon, which is necessary in this kind of procedure, because if we don't have that insertion healthy, we cannot perform this kind of reconstruction. We have to use another type of graft. We do a decortication of the footprint. We put a medial and anterior anchor and a posterior and lateral anchor. We perform a lasso loops again, trying to reroute the biceps tendon and to feel the most we can the footprint of the supraspinatus tendon. The objective at the end is to close the box as better as possible. This is the patient 2 years later with very good quality of movement and very good range of motion. When we have larger tears, maybe it's not enough to use just one bundle. So in these larger tears, it becomes a little bit more difficult technique. It's a configuration that we call the snake configuration because we put 3 or 2 bundles. I don't know if it's working. Well, to take home, superior capsular reconstruction with the long biceps tendon is a reproducible technique for many irreparable rotator cuff tear cases. We need the middle insertion of the tendon healthy. All the advantages of this technique should be considered, as we told before. Patient selection is of great importance. We have to have a healthy cartilage. It is not a panacea, as all techniques, because tendon transfers, for example, may be an option to consider when treating specific patients with anterior or posterior inferior cuff severe compromise. Thank you.